probably people in other ancestral territories as well. And that's where I'm presenting from today. So I'm going to lean heavily on analogy here to try and explain a few things about why people get fluctuations in medication response in Parkinson disease, as mainly a piece of background information of why someone would get to the point where this kind of therapy is actually worth considering and potentially helpful. So this is kind of in a nutshell, if you will, what I'll try and explain today. So how do medications work in Parkinson's disease anyway? What's going on with these fluctuations in treatment people can get? How does Duodopa work around that problem? And then we'll get into kind of who's the right sort of patient for this treatment, and practically kind of what happens when we want to initiate Duodopa therapy, and then what are some potential downsides or side effects. So we'll first get into this background piece, which I'll probably spend about 20 minutes on, because I think it's fairly important for understanding kind of why we tinker with medications the way we do, and when it's not working well, why Duodopa might make sense. So I want you to think about the brain supply of dopamine like the supply of bread at your local bakery. So a bakery is basically a place where this food that you need to use, unless there's even gluten-free options on here. I see spelt, so even if you're gluten-free, you may still need this kind of food as part of your daily supply for energy and nutrition. So think of the brain's ability to produce dopamine like a function like a bakery. It's producing this product. So in a bakery, the baker kind of knows how much bread they need for their customers, and they expect a certain amount to be used per day, and they make enough bread to satisfy that need. So if you go looking for bread and the shelves are empty, it's because the supply is insufficient for the need. So the analogy here is that in Parkinson's disease, the amount of dopamine that's produced in the brain is not sufficient for what's needed for the person's daily needs. And that loss of the ability to make dopamine in the brain is a very gradual process in Parkinson's disease. So at some point along the way where you're gradually producing less and less dopamine, or in the analogy here, bread, there's not enough product to meet your needs, and symptoms emerge, which could be tremor or stiffness or slowness or walking problems, for instance, or some non-movement related things too. So the bakeries would be these dopamine cells. This is like a diagram of the brain. This lower portion here where you see this kind of shape down here is the midbrain. That's where the dopamine cells live, which are like the bakeries in my analogy. And so on this side of the slide on the left, where you see it says normal brain, in the healthy state, there are many dopamine cells which are producing dopamine for you to use in normal daily life. And they send that dopamine up to this computer for movement we have in the brain, the basal ganglia. In the side of the brain shown over here, which is the example of a brain with Parkinson's disease, there are fewer functioning production units, or these factories making dopamine, or in the analogy I'm using, bakeries. So in Parkinson's disease, there are still some working dopamine cells that are producing dopamine, but they can't make enough to meet the need. So they are still sending some dopamine up to their target and trying to run that movement computer, but it's just not quite enough. So in a person with that, they would then develop signs of that showing up usually as movement problems. So in this analogy, so the ingredients to make bread, like your flour, your sugar, yeast, whatever you need, you basically turn into dough. And then once you've got the dough, you bake that into bread. So it's similar in the brain. Making dopamine is a process where you're taking amino acids, which are part of your normal diet. They're being digested in your stomach, and they get to these dopamine cells where they're turned into, over several steps, this precursor to dopamine, which is called levodopa. You can think of that like the dough that you're going to bake into bread, and then that turns from there into dopamine. And your brain cells, your dopamine cells, will store up that product, like putting the bread on the shelf for sale, so that it can be used on demand. Don't worry too much about the diagram. It's this concept that's important in understanding the medications. Okay, so here we have our baker baking some bread. So how do the different Parkinson's disease treatments work in this kind of concept? So one way we can treat Parkinson's if you don't have enough bread at the end of the day is trying to improve the production of dopamine by giving more ingredients. So levodopa is like giving people more dough. Partway through that process, we're not just giving yeast and flour and sugar, really, we're giving the last piece you need. We're just showing up and giving more dough to the baker so he can bake bread more quickly. Doesn't have to do all those other steps. He's just got the last step to look after, baking loaves of bread. So that's what levodopa is like in that analogy. There's other medications like dopamine agonists. Well, it bypasses the baker entirely. We say, well, at the end of the day, people are looking for some food here. So instead of going to your bakery, which is not working all that well, I'm just going to send people some donuts, and that'll stimulate the same effect that we get from baking bread and using that fuel. So we'll just give people a different kind of fuel. Instead of bread, let's use something slightly different that targets the same effect. That's like a dopamine agonist. And then there's other things that kind of make either the dough or the bread last longer. So you can think of that like putting your bread in a bread box, I guess, or maybe putting your dough in a Ziploc bag and in the fridge, and you can leave it to proof a little longer. You can still use the dough the next day, maybe. So those are things that we have that are kind of like boosters of the levodopa, like entacapone is a medication that's used like that. And then there's these MAO inhibitors that are used to kind of prolong the effect of dopamine in the brain. So those are kind of three main examples of different kinds of medications. So the tricky thing is that over time, the number of bakeries you have that are able to bake bread is changing. So this graph over here is a figure from a paper from the group in Vancouver looking at how much dopamine terminals you have in your brain over time in a person with Parkinson's disease. They can measure that actually using fancy brain imaging tools. And these little black lines here are individual people with Parkinson's disease and a map of how much dopamine function they've shown in their brain on functional brain scans over the course of their illness. So from the time they have their first symptoms being at time 0 down here through 20 or as long as 25 years, we can see a gradual loss. That's actually rapid initially and kind of slowly tapers off the rate of loss of the dopamine terminals. So that's like over time you got less bakeries. So you keep showing up with dough and they're not able to handle it well. So over time, since the production capacity in your brain is changing, giving the same amount of ingredients doesn't work quite the same. This is kind of reflected in how we think of how symptoms emerge over time. So people might have symptoms like constipation or sleep problems or mood problems well before they ever have a tremor or they have slowness or stiffness in a limb. And then when they're finally diagnosed with Parkinson's, you may say, oh yeah, well, maybe that was actually an early symptom of the disease. And then over the course of illness, people tend to get more complicated problems over time. The medication response seems to fluctuate more, and we develop more issues like non-motor symptoms, like problems with memory, problems with swallowing and chewing, and things that don't respond as well to medication. I hope you're still with me, because I'm about done with this introductory part here. But so the whole bakery analogy I wanted to bring out because I wanted to impress this point that initially when we give people these dough balls every so often during the day or medication like levodopa, the effect is you've got lots of bakeries. The bakeries are functioning pretty well. So you get a pretty consistent straight line effect, even from very infrequent occasional doses of medication. So you get a prolonged and more consistent response to medication early in the disease course. So over time, though, you get a less consistent response to the same kind of treatment approach. So if we give people the same kind of 3 dough balls a day kind of approach. One of them might work really well, but maybe the next one doesn't kick in as well, or maybe it takes longer. Maybe your treatment response is inconsistent. That's partly because later on in the illness, you've got less bakeries that are functioning well. So they can't take the dough and turn it into bread effectively. And then you also might have these are examples of people trying to first learn how to bake bread during COVID, the pandemic, and not doing so well. So your bakery can just not be making good bread all the time anymore. Sometimes the loaves aren't turning out. So sometimes your doses fail. They just don't seem to have the same effect. And there's a couple of reasons for that to do with the gut. So why do you get these bakery fails? So if a dose doesn't really work, it can have to do with how the medication actually is absorbed in the gut. So usually these little yellow molecules here, levodopa, and these little blue molecules here, other amino acids, are taken into the gut. You take them in with your food or by tablets of levodopa, let's say, and they're absorbed into your bloodstream. So the absorption of the levodopa in your intestine competes with other amino acids. So as some people experience, if you take levodopa tablets with a lot of protein, maybe that dose doesn't get absorbed as well. And that could be the reason why. Once you do absorb that levodopa in through your stomach into the bloodstream, it's taken through the bloodstream and the circulation up to the brain. And there in the brain, once it's there, it gets into the bakery or the factories, the little dopamine cells, and it turns that ball of dough, the levodopa, into bread. So that's kind of how the process works. So along the way, you can have problems getting the tablets down into the stomach, problems with swallowing. There can be problems within the stomach emptying the tablets. These levodopa molecules get absorbed in this big twisty thing called the small intestine or the small bowel. So if the tablets can't get out from the stomach into the small bowel, then they're not going to work so well. So that's a problem that can happen with Parkinson's called delayed gastric emptying. There's also sometimes problems with bacterial composition in the gut. So if you have abnormal bacterial flora in your small intestine, then some of those bacteria sometimes do nasty things and they turn the levodopa into dopamine down there in the gut. So then you can get less dopamine absorbed to get up to the coconut where you need it. So these things can be part of the story of why over time you get this kind of inconsistent response to the same dose you were on a few years ago. When at the start you say, well, I take a tablet, it never seems to wear off. Maybe I just need 2 or 3 tablets per day. Over time, people sometimes need to take them, 3 hours apart or 2 hours apart even to get a good consistent effect. So the summary, the take home from that is that issues with absorption of levodopa in the gut can lead to an erratic or delayed or inconsistent, incomplete response to the dose. Okay, so hopefully you're still with me. So if you're thinking about bread and stuff, I mean, it's lunchtime, so I understand it, but hopefully the analogy holds true. So then as doctors seeing people with Parkinson's, what we try to do to figure out how treatment is working for people is usually going to include the good old-fashioned history and physical. So we ask people, what's your day look like? How do things work for you with your doses? Does it seem to kick in? Does it wear off before your next one, etc.? Sometimes we ask people to do diaries of their symptoms to track like when in the day they seem to have good and bad periods of time. And that can sometimes pick out if you see the same problem, same time of day each day, that there's a little hot spot there that maybe we need to adjust treatment around. And sometimes we use fancy tools like motion trackers that are becoming more popular now as ways to track fluctuations of symptoms in Parkinson's disease. But so we do those things to get a sense of, are people getting a good consistent response? Are they getting this up and down kind of business? And then, we can kind of estimate how medication works in the setting where you have perfect absorption and delivery to the brain. So if you ignore all of that stuff that can happen in the gut and you say each tablet you take is absorbed perfectly, it can have an effect like a sharp little curve like this. This tool is developed by some Slovenians, I think, neurologists. It's shown at the website below there. but sometimes I'll use this tool to help people understand how the timing of the medication should work ideally. So a levodopa tablet might have an effect like this. Over an hour, it peaks and then it kind of gradually wears off. If that was 2 tablets, it might peak at about twice as high, but then also wear off. So then you might get someone's medication regime that looks kind of more up and down like this. And you can see this blue line across there. There might be an amount of dopamine where they have good control of symptoms, and their treatment is kind of getting them in and out of that window of good function. So what we try to do is, by understanding, asking people or looking at diaries and things, we try and figure out when in the day they're in that sweet spot where things are going good. And then we try and figure out, are there times where they're kind of over treated or under treated? And then we try and tinker around with the doses to get it just right. Over time, this gets more difficult because that window gets smaller where people are good. And we get less prolonged and consistent response to medications. So essentially, if you think back to this kind of progression of the illness, like the typical thing is, as time passes, people get more of these up and down fluctuations in medication response. People are also at the same time getting more of these more tricky non-motor symptoms, like problems with chewing and swallowing, problems with mood and anxiety, maybe cognitive problems, more risk of falls. So it makes it actually harder for us to also use other treatment approaches over time. So having gone through that first nutshell, so how does Duodopa actually work to try and bypass some of these issues? Well, this is the best idea I could come up with. It fits into the same bread dough kind of analogy. Is you know these machines that pump out the little donuts consistently. I remember being fascinated by these as a kid. You get this continuous production of donuts through this conveyor belt system. So the idea is to get a steady, continuous delivery of the dough up to the brain, to the baker. So the baker has one going into the oven every few minutes, and it's kind of automatic. So the idea is that if you can dial in the amount that you get that consistent good treatment effect, then you can bypass all of these problems with oral medications by mouth, that you get problems with the doses failing, or you get problems with consistent dose-to-dose effect. So how this basically works, looking at the same kind of diagram of a gut, is that it actually requires insertion of a tube through the wall of the stomach that goes into the duodenum, like part of the small intestine, and actually goes to the jejunum a little further. And what happens then is it's attached to a pump, and that is then programmed to the specifications that we think are about right for the person, and we kind of work to adjust it so that we get it as close as possible to a good consistent on. So if you think of this kind of window model again, the idea is something kind of like this squiggle here. So we might start up a pump in the morning for someone with a first morning dose, and then try and establish a good on state with that first morning dose, and then figure out what a good steady rate of medication is to keep them in around that right spot all day. There can still be dips in the treatment effect, and sometimes if the rate is too high, it can build up to be a little over the mark. And so people sometimes need to do extra doses or turn off the pump or things like that to try and walk themselves back down into the good on treatment window, or bump themselves up into that good on treatment window. So we do, as I was saying, we do that with basically a morning dose, a continuous rate of medication delivery, and then plus or minus extra doses delivered by this digital pump system through a tube that goes into the small intestine directly through the stomach wall. So, okay, who's the right patient for Duodopa then? Well, you have to have a condition that's responding well to levodopa. So, because all it is levodopa in a gel form instead of in a tablet form. Typically, and the indication for Duodopa on the product labeling for Canada, as it is elsewhere, is that people who are best suited to this have motor fluctuations, meaning they have this fluctuating response to medication, and or they have overtreatment like dyskinesia effect, like unwanted extra movements. And those problems are disabling. So it's not okay just to kind of wait it out. And despite adequate treatment of available oral medication options, they're still disabling refractory treatment problems. So then if you meet those two conditions, then we have to make sure that for the person that their gut is appropriate for putting a tube in, and that the benefits that we expect from this kind of continuous delivery of medication are going to outweigh the risk of putting a tube in and prolonged use of a tube over time. The other piece of that is we find it's best to have a situation where people have a good care partner and good support to be able to manage the tube system, because we're talking about something you need to kind of hook up and connect and turn on, even when you're in the morning and your symptoms are not well controlled. I promise I'm almost done. So then what do we actually do if someone seems appropriate for this? Well, so we want to review to make sure that they've tried appropriate medication options for things that could kind of level out medication effect, that there's not another way we can do this that doesn't require a procedure like inserting a tube. We then teach people and their care partners about the procedure and what the pump actually looks like, and then apply for coverage of the medication, which is quite expensive, through pharmacare or private insurance. And then once that's all squared away, if people are keen to proceed, it's time to send a referral to a gastroenterologist, which is a specialist in basically the medication and things for the stomach. So they'll insert one of these tubes as a special procedure. We then wait for the system to be ready to use, so it has to heal for a couple of weeks after. And what we do in that time is we estimate kind of what the medication dose people will need is for the day. And we then come up with a first estimate of what the morning dose should be, what the continuous rate should be, and what we should use as an extra dose. And then we do basically a 3-day process of adjusting the medication given by pump to make sure that these estimates are about right. And sometimes we find we need to increase the rate or increase the extra dose or whatnot. And there's a whole way we do that over a span of about 3 days. That heavily involves our clinic nurse, Daryl, who's joining us today. And so she'll be able to comment as well. Of course, it's important to think about this as a surgery. So people often think of this as an alternative option to deep brain stimulation surgery. And there you're thinking about a surgery where you're getting 2 holes in the skull and wires put into the brain, versus here you're talking about a hole into the stomach and a tube going into your small intestine. So there are always risks of doing a tube placement like this. There's complications with the tube itself. There's complications with the wound, which is called a stoma. And then there's some other things we have to worry about. So tube complications, the most common of these is that the tube gets blocked or stops working. So when that happens, we always need to have a plan B to get medication for a person with Parkinson's. And that's usually reverting back to a by-mouth medication strategy. The tube can come out if it gets caught on something or someone inadvertently takes it out. The tube can shift, like the end of where the tube is to deliver the medication can shift or change. And occasionally the tube could also be damaged or break and need to be replaced. With the wound itself, there's sort of scar tissue and sometimes leaking around the wound or inflammation or infection. And then we find with continuous delivery of the medication by a pump, sometimes people are more prone to certain vitamin deficiencies, and sometimes it induces weight loss as well. So there can be issues with that and with the pump that also need to be monitored. Having said all that, so this, I think, my last slide, just so you know. This is fairly new in BC as a therapy. There have been very few patients until recently who've had this therapy. This is some evidence from a recent study that looked at a bunch of studies at, how long does it seem to work for? Can people use this as a long-term therapy? This therapy has been available in Europe in certain places more than 15 years. And there are certainly people who use this as a long-term therapy. And there does seem to be evidence that it has a persistent effect, improving the time people have off where they're not moving well. But every kind of treatment approach like this has potential benefits and potential risks. So what we always have to do is look at what the options are for oral medications, if there's a surgical option, or this kind of device-based option like Duodopa, and whether the benefits and drawbacks of a system like this would be outweighing the benefits and drawbacks of other approaches. So with that, I'm going to stop and pause for questions. I think before maybe going on to introduce Jan and Terry, who are going to talk more about their own experience with the process. So I gave you a whole bunch of information there, and I know it's kind of confusing stuff. So I'm happy to take questions now or also at the end.
There are a couple of questions, Dr. Wile, in the chat box. I could read them for you if you like.
Okay.
Would this work for someone who has had gastric bypass surgery?
It's a difficult question to answer with certainty because the details of that might matter. So it should still be an option as long as the small bowel can still be accessed with the PEG J tube. So the tubing should still be able to deliver medication to the small intestine after bariatric surgery. So I think it shouldn't usually present a problem unless the surgery affects the small bowel in some way as well.
Okay, and so the next question with that was, does bariatric surgery cause more problems for the absorption of carbidopa, levodopa?
So it would depend on the details of the surgery. So the areas of the small intestine where levodopa, carbidopa is absorbed is in the earliest parts of the small bowel. So if a surgery included resection or removal of any of the small intestine, it could potentially affect the absorption.
Okay, thank you. Next question, is there a wait list? And if so, how long is the wait?
Yeah, so there was a change in the Pharmacare Special Authority listing for this product in December of last year, before which there was sort of a cap of patients per year who could receive this therapy. Presently, it's possible to have more patients approved for the therapy if they meet the criteria that are listed in Special Authority. So essentially, that's what I said. We need to make sure that we've tried all of the appropriate medication options and that people have still refractory up and down fluctuations. And then the steps that I outlined determine how long it takes to get going. So if we've tried all those things, which can often take many months, and we can't get good control of fluctuations or dyskinesia, then we might be going through the process of education, which can take, several kind of sessions and questions and answers back and forth. And then if we decide it's appropriate, referral to the gastroenterologist to get a tube placed is not usually too long, like on the order of a month or a couple of months. And then we got to wait for it to heal and then titration. So like the quickest it could possibly be done is probably 3 to 6 months. There are a lot of potential system barriers in there to getting it done seamlessly. So often from the time we decide we should consider this, it will be a bit longer than that to get it going. I hope that answers that question, but please follow up if not.
Okay, thanks. And the next question is, does this procedure eliminate the fluctuation due to protein consumption?
No. So if you think back to that little small intestine diagram, you're still ultimately getting levodopa absorbed through the small intestine into the bloodstream. So if you're getting a continuous amount through the day, but some parts of that day you're also eating, which you're going to have to do, you're going to have some times of the day where it's competing more or less with other amino acids and things for absorption. So there can, along with like a heavily protein containing meal, be a little dip in the effect. So sometimes people will then notice that their tremor comes back or their symptoms get worse around the time of a protein containing meal. And we sometimes are able to figure out a way to offset that with an extra dose. And if not, then sometimes we catch up with an extra dose after a protein containing meal.
Okay, and the next question is, the pump I'm told is 2.1 pounds. How is it carried?
Oh, that's a great question. I think probably Jan and Terry can comment on, as well as anyone else who wants to. But there's a number of stylish options for carrying the pump. I do agree. There was talk at some point of the pumping miniaturized. I'm not sure that's still happening, or if so, when. But it is, it's fairly sizable. Maybe Jan and Terry can show when they have a chance. But it's usually carried with either like a fanny pack, or there's like a shoulder bag, or there's like a vest. I've never seen anyone choose the vest. I think most people choose the fanny pack. But yeah, you're trading the hassle of taking pills every few hours for the hassle of having this tube and this pump. And so it is definitely not like a straightforward thing where it's going to be a lack of nuisance factor. There's definitely the nuisance factor of carrying the pump around, and these cassettes that are full of this gel that has to be refrigerated. Takes up half your refrigerator, I would think, because they send you 30 packs at a time. But I know less about those practical daily hassles than Jan and Terry, so I'm gonna leave that question partly for them.
Okay.
I think there was one too, Alana, I saw ahead of there that I just wanted to make sure we didn't skip over, which was from Bob. Oh no, this was direct to me. Okay, so that's why it didn't show up. So the question was, is the primary benefit to overcome inadequate emptying of the intestines or inadequate cinematic absorption? And so basically, I would say the main benefit is to eliminate these issues we have with inconsistent effective oral medications. So these fluctuations in response and sometimes dyskinesias. And that's partly from the stomach emptying issues, but it's partly also because once the stuff gets up to the brain, the way the brain handles the medication is getting a little more flaky over time. So it's both those problems that the consistent, steady rate works around. And then I'll just return back to the next question I saw, which is, who is right for this therapy? So yeah, I mean, I could go over that again. It's basically for people who have these fluctuations in treatment response, or they spend a lot of the day where their medication's worn off, or a lot of the day it's not working, a lot of the day where they're over-treated with dyskinesia. And we've basically thrown the kitchen sink at it with respect to other treatment approaches, and we can't get a satisfactory result. There's another question there about specific type of leukemia. If there's a stable condition like that, whether this would still be appropriate. It's a bit hard to answer a specific like that because it would depend on a lot of details. And it would probably require discussion with the treating doctor for that other condition, especially depending on it effect on medications, other medications, and effects on the gut and things. Then there was a question about going swimming. So there are certainly ways to do that. It basically requires disconnecting the pump. People obviously also have to shower. I'll invite Jen and Terry to comment on showering and swimming and stuff like that, because I'm not actually living with the pump system, and I think they'll probably give you a more realistic view of what that's like. And then the question, what is the success rate? So of the patients that we've had, I would say it's very successful, and it's usually with tricky fluctuations that we are considering this, and it's people who have basically tried more or less everything. And I think most of our patients have found it very effective in the way I've described to you. Looking at the broader kind of literature on it, there are people who stop therapy within 2 years, usually due to issues with tubing or the wound or infection, but that's a small proportion. And it's something on the order of 10% or something like that will stop it within 2 years, but I don't have the number on hand. Most people are happy with it. We haven't yet had someone who's reverted back to oral medications because it wasn't successful. Sometimes it's tricky to get the titration right, I would say, to get the adjustments right. And we need to take another crack at that after the initial settings. But I think we've heard more than enough of my voice now. And the more important thing is the real perspective of people who've gone through this process. And I'd like to, at this point, thank very heartily Jan and Terry Gibbon for offering to give their perspective on how this has gone. I'll introduce them and I'll invite you to unmute, and I'll go ahead and turn my mic off. Thanks, Jan and Terry.
Here we go.
There you go. Am I ready?
Yep, I think so. Good afternoon.
Well, I'm going to speak. We're sort of in a trade. You get tired of me, and then Terry will jump in, and etc. But I was diagnosed 21 years ago. So I was 45. I know I'm fine. And I didn't need meds for the first bit, and it was a very gentle start. I used to swim with the master's program, and that was one of the first indications that something was wrong, because the coach kept saying, kick, kick. And I said, I am. No, well, you're not. And so that wasn't very good. The typewriter wasn't very good, that typewriter computer, because I would have enough of a tremor to just hit the keys more than once. So I did E, E, O, 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 and so on. So that was how it started. And I didn't have any medication, as I said, for the probably the first 4 years. What do I want to say? I was able to, because I wasn't on the meds, they liked having me for studies. So I was on several of those, right in the US, down to Yale, Connecticut. And that was I went back 3 years in a row. And the study ended up being pulled because there was no indication that this med they were trying to get through would work. We've lived in several places during this time period. So I was treated at Ottawa Parkinson's Disease Movement Clinic, where David Grimes was there, Pacific Parkinson Research Center, Dr. McEwen, and here in Kelowna with Dr. Wile. I think that's it.
So with regard to Jan's pre-Duodopa experience, 2016 was when Jan was diagnosed as having attained advanced PD. The most challenging times with her Parkinson's were times when she had excessive levels of dyskinesia. 1 year she lost close to 30 pounds. Another time is that she was having respiratory problems, which still exist to a certain extent, almost as if somebody was sitting on her chest. The on time in any given day could probably be a total of 2 hours dispersed during the day. There was freezing, stalling, shuffling, and balance issues. And Jan was also having difficulties with memory, cognitive challenges, as well as anxiety issues. So in 2018, Dr. McEwen determined that probably was, as described by Dr. Wile, the oral medications were no longer optimized. And the recommendation was made at that time to either pursue a duodopa option or go through with deep brain stimulation. Duodopa at that time, I think they were only doing about 5 operations a year. It was fairly new in BC, as was explained earlier, and we were sort of on the cusp. So fortunately though, from 2018 through to 2019, Pacific Parkinson's Research Center did a yeoman's job in getting things done and getting Jan pushed forward, having to be considered for the Duodopa. And that sort of culminated in the summer of 2019, when somebody from AbbVie, which is the Duodopa mothership, if you will, came out to see Jan and did an evaluation. And then we were subsequently referred to Dr. Wile for consideration and to be put on the wait list. Prior to Duodopa, Jan was taking 6 different Parkinson's medications a day over 7 different periods in the day, totaling about 20 pills, give or take, every day. And specifically going up into the fall of 2019, just before she had her procedure, she was only having 2 hours of on time per day, significant dyskinesia culminating often in Jan becoming sick to her stomach because of the movements that she was experiencing. And when she was either not moving or throwing up, she was experiencing great difficulties with breathing. As it looked more promising for Duodopa, Jan was weaned off all meds but the levodopa carbidopa combination of meds, so that she would be in an optimum position to migrate to just having the Duodopa medications.
So January 30th, 2020 was when I had the first procedure to create stoma and insert the PEG-J tube. That I had, there were 2 gastroenterologists that worked on actually both of these, because I start with, that's when the first time was. Everything went fine with very little fuss, except the first time we made a grave error and going to a shop that had soup and sandwiches, and we're told that the soup was fabulous. So I had the soup, which was very spicy, which I discovered almost the minute I took it, that I'd made a grave error. I don't know, I say that I would have had at least 2 of our 3 children to go through that again.
Yeah. So the moral of the story is don't have spicy soup after you have your tube put in.
Exactly.
When Jan started the Duodopa, it was about 10 days after she had the procedure done. And within 20 to 25 minutes of starting the Duodopa titration, it was as if all of her problems were gone. So from the previous day, where she only had 3 hours of on time, from the time she started her medication to the end of the day, she had about 13 hours of being on. It was miraculous, just simply miraculous. The titration period and the experience with the Duodopa and understanding it, thanks to Cheryl and Sherry, lasted about 4 days, and it was the start of something just amazing. The challenges experienced that Jan had on February 25th, which was about 2 to 3 weeks after the operation and then 2 weeks after the titration, there was a high pressure alarm that went off on the machine, the pump. Yes, thank you. And trying to figure it out proved to be a little bit of a challenge, because given the newness of this procedure, trying to get a radiologist in Kelowna to figure out how to take an image of the tube proved to be a challenge, and we wound up having to go back to the gastroenterologists so they could figure out what was going on. And ultimately what happened is that subsequent x-rays that we got from the gastroenterologist determined that there was a kink in the tube. And as such, a second tube was put in. Jan went to plan B, which was a return to the oral medications, and a fairly significant disappointment. But she, on March 26th, approximately a month after the alarm went off on her pump, she got her second tube. And then in going back for verification to make sure that the tube was fine, on March 35th, so 5 days later, they took an x-ray and they determined that there was a problem with the placement of the tube, the second tube. So they went through and put Jan under in a general anesthesia this time and used a fluoroscope to optimize the placement of the tube between the stomach and the small intestine. And it's been in ever since. So the third tube wound up being very successful. And what they explained to us is that the sedate nature of the stomach with the active nature of the small intestine caused all sorts of things to go on, and the tube would be prone to being kinked, at least with Jan's anatomy.
Okay, and we're getting there. December 20th was when I discovered this growth just on the wall of the stoma. And it was diagnosed as granulation or chronic inflammation. It caused great discomfort. It's still very uncomfortable, bleeding almost every day. And I thought, well, this is really no way. Well, it was not much fun. At least a 2-shirt day, I could tell what day it was or how bad it was. And it seemed to be caused by friction movement more than anything else. So Cheryl got on her white horse and contacted the movement disorder clinic, the AbbVie, as well as the surgeons that did the stoma and put the tubes in. And it was determined that either be excised, treating the wound, or by treating the wound with silver nitrate and antibacterial creams and so on, which is still happening to today. So October 7th is coming, and that's when they're going to replace the tube again.
And these tubes are all done in ambulatory care. So it's not a surgery per se. The initial cutting to make the stoma was a surgery, but these others are considered to be procedures. And generally, all with the exception of the last one, Jan was just given something to calm her during the procedure. So there wasn't a necessary general anesthesia. Some of the things that are the small challenges and the pet peeves with the system is the pump seems to get heavier and hotter as the day goes on. So it is it's a burden. It's not a burden. It's a pain in the sense that
disadvantage.
It's a disadvantage. There you go. Having had, that's mine, I'm sorry.
Yeah.
Having had the problems that we've had, considering that there's been 3 tubes and eventually a 4th one next week, and a couple of other things with stoma and the growth through granulation, you know, we're devout followers of the Duodopa process. It's given a quality of life that we haven't experienced in many years prior to Jan going on to Duodopa. But we're curious and a little hesitant about the actual ancillary things. Like, is the pump going to keep on working, and will we have a problem with the pump? It's never about the drugs. Is the tube going to keep on working, and what are we going to do about the tube and things like that? So that sort of lingers, but it's not about the Duodopa as a medication regime.
Okay. Delivery of the meds sometimes is a challenge because they like to deliver between 8 a.m. and 5 p.m., which is a fair bit of time out of your day.
Yeah, if you're not aware, the medications come out from a central location. I believe ours comes out from Burnaby, and they're packed in freezer packs, so it's freezer bags in there to keep it cool during the shipping period. It winds up being sent out. It's not as if you go to your pharmacist to get it. It's delivered door to door. As Dr. Wile was mentioning, the space that it takes up in your fridge, one box, but you get 4 at a time, it's about the size of a small loaf of bread. So you have to sort of figure out whether you have space in your fridge or if you even need to get a small bar fridge, which we wound up doing.
The other thing is, my GP didn't know anything about it. I brought him a copy of a couple of the little books that we got. And we've just found that many medical professionals are just not aware of it. And I was just surprised, I guess. I figured they kept up, but not with everything.
Yeah.
Okay.
So I'm not sure why I'm saying this, but not many outfits are complemented by fanny packs. So if you're fashion conscious, that winds up being something that you have to be considering. Bath, swimming, or choosing age-appropriate bathing suits when you're on the beach has a tendency to be a challenge as well. We haven't figured out, we're swimmers. We haven't figured out how Jan can swim or even have an immersion bath, if you will, aside from wrapping her up in cellophane, from head to toe to make sure that there's no water that gets in. And if you travel, it's about being able to, there will always be medications. AbbVie has been amazing with that. But it's making sure that you have the space available in fridges, whenever you get there. So, do you want to run through this?
Yeah.
Okay. So the important points to remember about the Duodopa is,
What is that one? Let me choose to put it on.
It remains flexible, as Dr. Wile referred to. The dose is a constant during the day. You have an opportunity to boost as needed, but you can fine tune it as well, depending on how you're doing through the day. And that could depend on how active you are, or if you're eating protein or anything else like that. So it's ultimately flexible.
So really, we're just cutting hairs here, because we've already said that Duodopa is probably the worst Duodopa day is the best, still the best by far in using oral meds.
We'll ignore that, sorry. Now, the other thing that happens with Duodopa is that, in as much as our neurologist is Dr. Wile, we really do have a team of people that come with the Duodopa experience. Dr. Wile and Cheryl Daniels from the Movement Disorder Clinic are our go-to people. Cheryl, I don't know how many times we sent her an email, and within minutes, if not, a very short period of time afterwards, we've got a reply to any of our questions. Jan also has 2 gastroenterologists that she goes to, having to do with the tube placements. There's a wound care nurse that's been helping Jan take care of her granulation with the stoma. The pharmacy company, which is the Shoppers Drug Mart in Burnaby, does amazing stuff with that. And then there's also the AbbVie team, which is always available for us to consult with if we need to have that, but we'd normally be going through Cheryl. And that team is not only regional, but it's also national and international. So they have all sorts of information with that. From a Carepartner's point of view, we've never really felt that or treated ourselves as being a care partner and a patient. We see ourselves as being a couple of units. So as we look at the things having to do with Parkinson's disease, we both live it. Although Jan has the Parkinson's, I'm there to support her on many things. With the Duodopa, there's been very little for me to support her with. Jan is independent enough now that she can manage the use of the pump and putting things on and off. There have been occasions where the batteries, getting them going, the cap that is on the cassette is a little too tight that I'm there for. But she's completely independent, with the exception of maybe once or twice, I don't know, a month or every 2 months that she needs a hand from me. Although we do have friends that are on the Duodopa system, and as was suggested by Dr. Wile, there are some people out there that need to have a partner to be able to put the cassette on and hook the tube up in the morning, because they are incapable of being able to do that on their own. So I can see where a partner would be very critical in that sort of situation as well. I think the biggest thing with all of this, aside from the benefits of the Duodopa, is that we feel like we're embraced by a team of people that are supporting us on this. It's not just Dr. Wile, it's not just Cheryl, but there's a community of practice out there that's second to none in making sure that this is going to work for us.
That's it.
That's it. Thank you.
Thank you.
Thank you so much. And I would really underscore that too. And Cheryl is here with us today as well. And I'd really emphasize, Cheryl does far more work on getting things running effectively with patients with Duodopa than I do, really. And so we do work as a team on it, but there become a lot of other issues that are actually handled much better by other healthcare team members. I just really want to thank you for giving such an honest description of your experience. I would say your description of your experience is similar to, I think, most of the patients we've had go through this, in that there are sort of a lot of little things that come up after for most patients. I think that's common to have little wrinkles and roadblocks that are usually things we can get around. But most patients, I think, that we've had go through this seem to find that the benefits are well worth those hassles. So I'm happy to kind of take or moderate any more questions. And I also invite Cheryl, if you wanted to comment at all on titration or the process from your perspective, certainly that's welcome also.
It is Cheryl, and I would like to make a comment. Yeah, basically what you said, I think Jan and Terry's experience is pretty typical. And I just want to reflect back on the last question before they spoke, is what is the success rate? And so success is whatever it ends up being for the individual living with the Parkinson's and going through it. And so the successes are going to be different. But for the most part, it has, sort of widened the ability of people to live and do the things that they want to do in their life. And that doesn't mean that there aren't sort of challenges along the way, or, still bad days and things like that. That all goes along with Parkinson's, but for the most part, it's smoothed out. But so in many cases, it's successful. But when the Duodopa was studied, when they did their clinical trials with it, success was described as having 4 extra hours of on time. So in a day. And obviously from Jan's perspective of having maybe 2 and split out into little chunks throughout the day, 4 continuous hours of on time is incredible and amazing. And I think most people do achieve that. And in many ways and times much more than that. But, we always have to spend time talking about being realistic with what the outcomes of the treatment are going to be. And we spend a lot of time talking about the fact that it is just another treatment method. It's another delivery. And you still do have the other challenges with Parkinson's disease along the way. But most people, once they've been on the pump for a while and they do have to go back onto their oral meds, then they really can find the significant difference in their life with Duodopa.
Cheryl.
Thank you. I'll just highlight as well a comment in the chat from Wendy Ollinger, who's also, she's volunteered here that she's a patient that we've had go through this process as well, and that she's found it very effective. Wendy, you certainly don't have to comment further. If you like, though, you're welcome to. And I'm happy to take any other questions too, or Jan and Terry, I'm sure as well. There is another question in the chat. So the effects of stress on symptoms. Does this system cause more stress for the patient? Maybe I'll reflect that to you, Jan and Terry. It is very true that most people find stress of any type will amplify their symptoms and make things more challenging. And I think that, again, is a very individual thing to answer. But what would you say?
Well, I think that any stressful situation is amplified now. Like, there's no such thing as a little stress. It can be good stress, it can be bad stress, doesn't matter. It just, what's that ad on TV? It just doesn't matter. So it definitely affects. It doesn't affect. I don't know what it's affecting, whether it's, Dr. Wile you'd probably be better to answer that, but it certainly does affect the functioning and the symptoms. And
if I can just add, one of the side effects, if you will, even on the oral medications, is that stress, whether it be joy or actual stress, anxiety, was affecting Jan quite a bit. If I understood the context of the question, does Duodopa cause stress? No, it doesn't. We were constantly, over the 7 periods in a day that Jan was, working an alarm to remind her to take her medications. And if you're in the middle of something, then the alarm goes off, you turn it off, then you forget you take your medications. It was far more stressful to manage the Parkinson's before than it is now in managing Parkinson's with the Duodopa system or regime.
you just you plug in the morning and you don't have to think about it unless you're giving yourself an extra boost.
That's the thing I think people have emphasized with me, is that people who go into this therapy decision often have so much up and down in their day. Just having some time in the day where they're not constantly vigilant and thinking about their next dose and things like that, having it running in the background is actually tremendously relieving in a way, because it just gives you a bit more predictable function, I think, for most people.
Yeah.
But yeah, certainly in some stressors with the pump and the system.
It also, that we have experienced is that, the holistic side of taking care of yourself, in offering diet and rest and exercise and eliminating stressors is easier done now than it was at any time during the oral medication regime. It gives you more time to concentrate on yourself as opposed to, those cursed meds.
Yeah, so I was going to say that I think obviously initially going into it, there is a bit of concern, stress, or worry about going through the procedure and working with a pump and living with it. But I think very quickly that people who go through it start to see the benefits over the downside. And we also talk very much at the beginning how, depending on where people are in their Parkinson journey, it took them a long time to get where they were the day they present for their Duodopa. And, when you plug in and away you go, it's not an automatic switch over to your new way of life. So it does take some time to kind of deconstruct the way you have come to live your life and how you are living moment to moment with the pill schedule, and have that kind of back up where you can be more relaxed, like Jan and Terry. So it certainly does happen, but it can be a process of making that readjustment in your life and realizing that you do have time to do things, and starting to also, we talk about trust that the pump is going to work and the medications are going to work, because you've spent a lot of time up to that point not always relying that if I take a dose of medication, is it going to bring me on, and how long is it going to last? So it is a bit of a process, but usually, as I said, when people are required to go back to their old way of life, they really notice the difference there.
Yeah.
I guess the other thing I want to say, like John and Terry mentioned, is that, they aren't out there on their own. And so certainly they're in touch. Anybody having issues is in touch with me. They have contact with Advocare at the other end if they're having issues with their medication, if they require any of their supplies, any of their carrying devices, if they need anything else that with the delivery of their medications, they're able to receive carrying devices and extra. There's sort of a binder thing that you can wrap your tube up in overnight, or if you need more syringes to flush your tube, if something happens to your pump, they can send you that, etc. So those people are readily available to help support you.
Cheryl? There's also Cheryl. Am I in?
I don't know. I think so.
Can you hear me?
Yep.
Oh, okay, I'm just gonna say, everybody's there for support, but there's that one person, Cheryl, that looked me in the eye and said, do you realize you have advanced Parkinson's? As we were walking around the circle in the office and trying to measure out how I was reacting to this new pump. She just looked me in the eye and said, you know, do you really realize? I do now. Thank you.
Yes, everybody should have a Cheryl in their life.
Cheryl's not on video right now, so we can't see her. It would be nice for her to say hello, but thank you for also commenting, Cheryl, and being here. I think we have another question.
I am. Hello, everybody.
Yeah, there's a question from Vern. Is sleep better with Duodopa? Loaded question. So a lot of people with Parkinson's will have issues with their medication wearing off, interfering with good sleep. So as medication wears off, a lot of people experience non-motor wearing off symptoms, including restlessness, anxiety, temperature changes, flushing, sweating, things like that. And often when people are on an oral medication regime, the end of the day is when the last dose is taken. And so through the early part of the night, there will usually be an episode of wearing off. And so if people have those things, that can often make it very difficult to get asleep or stay asleep in the early part of the night. With Duodopa, the most common pattern is to run the system about 16 hours a day and shut it off, flush the tube at night, disconnect it, and go to sleep without the system running. So there is still the potential for that shift in how your body is working when the pump is flushed and turned off, including some wearing off effect. So I don't know, Jan, if you've got any comments about how your sleep has been affected with this system.
Well, initially, and probably for a good half of a good 10 years, my head hit the pillow and I was gone. I had a wonderful sleep, didn't do anything. As time progressed, and I'm trying to think whether it's actually with the pump or just time, that I don't find it as easy. And it is the beginning of the sleep. If I can get to sleep right away, that's a bonus. And melatonin helps on occasion.
Yeah, I can attest by being her partner in bed, is that her sleep is more sound now when she does get to sleep. Before there was a lot of talking in the middle of the nights, there's storytelling, on occasion aggressive moves, so with the Duodopa, there's been far less of that, significantly more. It's a more peaceful sleep.
Question from Donna in the chat: is dyskinesia better controlled with Duodopa? I would say without a doubt that is a major advantage because often some of the things that we do with oral medications to try to reduce off time results in more time where you have on with dyskinesia. And so the Duodopa often is quite effective in reducing that on time with bothersome dyskinesia. So we typically think of a good result as on time where there's no dyskinesia, or on time with mild dyskinesia where it's not causing you to step unpredictably or fall over or bump into things. So there's a difference between having mild and then kind of moderate or severe bothersome dyskinesia. So certainly it's quite helpful in reducing the amount of dyskinesia and the severity of it, I think, for most people.
The reason that this works so well this way is the makeup of the medication. So it's still levodopa, carbidopa, and it is in a different form. But the amounts that we can provide through the pump are much smaller pieces than would be had you taken a full tablet or half tablet or what have you. So we can dial it in much tighter and keep you more online and less on the under or over treated side.
Of course, I'll just maybe point out as well that we're in the interior health region, as I kind of introduced with the territorial acknowledgement at the start, and probably a lot of our guests are from around the province. And so I would just also comment that there are a few places where duodopa therapy is being started in the province right now, but it's not in all four corners kind of thing. So probably the center where most duodopa initiations are done is still in Vancouver at the Pacific Parkinson's Research Center. And to my knowledge, they're also starting some patients in Surrey at the Jim Pattison Memorial Outpatient Surgicals, whatever it's called, in Surrey Memorial, where the movement disorder clinic is. And I'm not sure if they've yet started patients on Vancouver Island at the Victoria Movement Disorders Clinic, but I know that was something that they had wanted to begin there also. But typically it's done at a center where you do have a movement disorder specialist who's familiar with duodopa, nursing support, and a gastroenterologist who's trained in the specifics of this kind of unusual tube system. Any
Okay,
kind of any other questions, or Alana, did you want to take over at this point?
yeah, I mean, I don't see any other questions. I can wait a minute if there are more questions coming through. But I do want to thank you very much, Jan and Terry, for taking the time to share your experiences. And again, thank you, Dr. Wile. And of course, Cheryl, thank you. Thank you for being on camera with us so we could see you here towards the end. And yeah, so thank you for an informative presentation, and thank you all for attending and for your questions. Also, before we end, just a friendly reminder that our provincial conference is approaching on October 6th, and we have a great lineup of plenaries. So please check out our website under events for more information and to register. And so if there are no more questions coming through, I think we can end this and wrap it up. And thank you again for attending. Have a great afternoon, and bye for now.
Thank you.
Thank you.
Have a good day.
Thank you. Thanks again, Jan and Terry. Bye now.
A pleasure.
There we go.
Sure.
Yeah.